with ALL being a relatively more rare disease than AML, there's perhaps not as much investigative work on transplantation in ALL, but allotransplant does remain the accepted gold standard method for curative intent in patients with high risk or relapsed ALL. And so there are quite a number of patients with ALL, particularly in the adult age group, who end up going to allotransplantation. I think in terms of novelty, one of the more recent advents is the use of alternative donors, in particular haploidentical donors. And data from the Center for International Blood Marrow Transplant Research show that there is indeed an increasing use of haplodonors for patients with ALL. And there are now emerging data sets showing very similar outcomes with haplodonors compared to more standard sibling or matched unrelated donors. And so that means haploidentical donors are a suitable alternative for patients with ALL. An additional alternative donor source that's developed some data are cord blood transplants. And there are some studies showing great outcomes with cord blood transplantation. So I think that we can now say that we can find a donor for essentially every adult who has ALL and warrants an allotransplant. So in terms of novel developments for managing the transplant, most programs have largely settled on favored approaches for conditioning with myeloablative or reduced intensity conditioning. And I would say there's not a lot of innovation necessarily in the conditioning regimens, but there's certainly innovation in the pre-transplant and post-transplant management of patients. One of which is the achievement of MRD negative status using blinatumomab prior to transplant. And then in the post-transplant setting, monitoring MRD in serial fashion, that's measurable residual disease, monitoring MRD in a serial fashion to make changes to therapy, either early immune suppression withdrawal or implementing blinatumomab after the transplant to try and optimize the likelihood of a long-term disease-free survival. There are some ongoing studies that are very exciting, looking at both prophylactic and preemptive therapy for patients with ALL. And hopefully these will show us better ways of maintaining MRD negative remission over the long term and curing more of our patients.